Today's Telehealth Immersion Program event is focused on demonstrating the value of virtual care, and we are excited to host today's session in collaboration with the American Telemedicine Association in observation of the second annual Telehealth Awareness Week. Telehealth Awareness Week this year is focused on the theme of highlighting the value of virtual care. Through a week-long series of national and regional events, this initiative aims to explore the role of telehealth in care delivery, provide new educational resources focused on the key advantages of hybrid care, and elevate the voices of patients and healthcare professionals who depend on telehealth to receive and deliver care. The AMA is proud to be an endorsing partner of this event. My name is Bernadette Lim, Senior Manager of Digital Health at the American Medical Association. And today I am joined by my colleague, Laura Fritchie, Project Administrator of Digital Health, and will be your host for today's session. Okay, a couple of quick housekeeping notes on the front end. This is our brief disclaimer. The event will be recorded and made available after today's event. And then our virtual discussion today will be held on the AMA's Physician Innovation Network. So we invite you to scan the QR code on the screen and interact with speakers and each other's throughout today's event. So I'll just give you a moment here to scan that. And we'll put that on the chat, and I think there's also a link in the resources. During our 2 hours together today, we will start off with brief opening remarks from Ann Mon-Johnson, CEO of the American Telemedicine Association. We then have Sandy Marks, Senior Associate Director of Federal Affairs from the AMA, joining to give us a brief policy update on telehealth legislation and CMS telehealth policies and proposals. We then have Dr. Vimal Mishra, Director of Digital Health Strategy at the AMA, who will give us an overview of the AMA's Return on Health framework and really set the stage for our discussion. And then we're excited to have 7 organizations joining us today that have measured the value of virtual care in their unique practice environments. Each will highlight the value that's been demonstrated across the value streams in the AMA framework, and we will spend any remaining time going through any Q&A. All right, and it is my privilege to introduce our first speaker today, Ann Mon-Johnson. Ann Mon-Johnson is the CEO of the American Telemedicine Association, overseeing the only association focused completely on advancing the adoption of telehealth. Under Ann's direction, the ATA is focused on federal and state policy initiatives needed to ensure permanent access to telehealth services so that everyone has access to safe, effective, and appropriate care when and where they need it. Ann has been a pioneer in healthcare for more than 2 decades as both an entrepreneur and executive leader, and has launched and built innovative companies that have leveraged data, decision support tools, and digital apps to make the healthcare experience better for consumers. And Ann, I'll go ahead and turn it over to you.
Ann Mon-Johnson, very excited to be here and welcoming all of you to the final day of Telehealth Awareness Week, and really the capstone of our webinars and different programs that we've had this week. Demonstrating the value of virtual care is really so important to all of us. And it's really reflected in the work that we're doing both at the ATA and in conjunction with partners like the AMA. I will say that Joe Kvedar, who's the immediate past chair of the ATA board, along with Christy Henderson, who is our current chair, both very much dedicated to the notion of demonstrating the value. And Joe in particular, in his role as a clinical advisor to the ATA's Center for Applied Research in Telehealth, has been very engaged in this as well. So we're excited to have Joe. We're excited to be in front of you. Telehealth Awareness Week, just as noted, this is the second annual Telehealth Awareness Week, and it's really part of our effort to ensure that telehealth is available to people where and when they need it. Whether you call it digital health, virtual, telemedicine, virtual care, the reality is the ability to leverage technology to reimagine how care is delivered to everyone in the United States and around the globe is really top of mind for us. In addition to Telehealth Awareness Week and the webinars that we've seen today, we're also advancing a lot of work around disparities and equities and how telehealth can be used to address those. One of the webinars earlier this week focused on our latest finding, which is the correlation between life expectancy and the digital infrastructure. And so I invite you to go to telehealthawareness.org and look at that webinar, as well as the many, many other webinars that have come out of our member-led special interest groups. The programming for Telehealth Awareness Week and the fact that we have over 50 endorsing partners, many of whom are patient-facing organizations, really speaks to the importance and how telehealth has become a household word. I'll also say that we have launched ATA Action, which is our affiliated trade organization focused exclusively on promoting and advocating for policy and regulation at the federal and state level. And this week, they also announced the formation of the Patient Voices for Telehealth Coalition. Again, a remarkable assembly of many, many organizations who stand by us and all of you in ensuring that telehealth really becomes permanent. As you'll hear from Sandy, there are a lot of reasons why we can be optimistic, but we also have to be vigilant about ensuring that regulations and laws that make telehealth permanent are actually passed, both at the federal and the state level, so that at the end of the day, we all know that telehealth is health. And please join us in using that hashtag as you promote this webinar, as well as everything else that's going on this week within Telehealth Awareness Week. With that, let me thank our partners at the AMA again for giving us the opportunity to speak and for making this webinar such an important component of Telehealth Awareness Week. Thank you.
Thank you so much, Anne. All right, it's my honor to introduce our next speaker, Sandy Marks. Sandy Marks is Senior Assistant Director of Federal Affairs at the American Medical Association's Washington office. She is part of the AMA team advocating for public policy on Medicare physician payment and alternative payment models, telehealth, and public health issues, such as the drug overdose epidemic. Sandy, thanks so much for joining us. I'll turn it over to you.
Thank you, Bernadette, and good morning, everyone. So I think the key word people think about when we talk about federal policy on telehealth is flexibilities. So Congress and CMS provided a lot of flexibilities at the beginning of the coronavirus public health emergency that really allowed the dramatic increase in adoption of telehealth that we've seen during that pandemic. It allowed patients to continue to receive services in their homes and physicians to provide services from their homes at the beginning when everyone had to stay at home. It also has allowed hybrid models to flourish in the time since then, where patients can get services in person or virtually, whatever modality is going to be best meet their needs, including telephone services. So what we need to do in the future is make sure those flexibilities continue. What Congress has done so far is pass the 2022 Consolidated Appropriations Act. This act lifts all restrictions on the sites across the country on where the patient can be located who has Medicare to receive telehealth services, including their home, for 151 days beyond the end of the public health emergency. It extended telehealth services for occupational, physical, and speech therapists, as well as audiologists, for 151 days, extended distance site telehealth for federally qualified health centers and rural health clinics, delayed the 6-month in-person requirement for mental health services to be provided via telehealth, extended audio-only telehealth coverage, and extended first dollar coverage of telehealth as pre-deductible for HSAs through the end of the year. It also required some reports in June of 2023 from MedPAC and from the HHS Office of Inspector General on telehealth utilization and its program integrity risks. So what exactly does 151 days after the end of the COVID-19 public health emergency mean? This public health emergency has to be renewed by the Secretary of HHS every 90 days. The most recent renewal was effective in mid-July, and it goes until mid-October. the Secretary has pledged to give at least 60 days notice to everyone before the expiration of the public health emergency. So we always know 2 months before the next expiration that it's going to be extended again. When the public health emergency is renewed in mid-October, that will extend it until mid-January of 2023. Now, 151 days is about 5 months. So if October becomes the final extension of the PHE, then the extensions I just mentioned in the previous slide will take these flexibilities until mid-June of 2023. So that's pretty good, almost through the middle of next year. But additional legislation is clearly going to be needed to further extend those flexibilities and make permanent access to Medicare telehealth services around the country. So far, there are several bills that would do that. Most recently, on July 27th, the House of Representatives passed a bill called the Advancing Telehealth Beyond COVID-19 Act, and that was by a vote of 416 to 12. It would extend the telehealth flexibilities in Medicare for an additional 2 years. And the vote, the overwhelming vote, really demonstrates that telehealth is very much a bipartisan issue. Now we need the Senate to pass a similar 2-year extension and continue to push for a permanent extension. The AMA is supporting and is asking members of Congress to co-sponsor 3 bills that would make availability of telehealth permanent. The Telehealth Modernization Act of 2021, the Connect for Health Act, as well as the Telemental Healthcare Access Act. On the CMS side, CMS made enormous changes in its policies for Medicare during the COVID emergency. It added about 150 services to the Medicare telehealth list, including emergency department, critical care, home visits, and telephone visits. It created a category 3 of the telehealth list, which are codes that will be covered through 2023 on an interim basis. And this is supposed to allow the data to be gathered and provided to CMS to help them decide whether these services should become category 1 or 2 and be on the telehealth list permanently. An additional category of services doesn't have a number. It's not called category 4, but these are services that were added to the list but were only slated to be covered until the end of the public health emergency. In the recent Medicare Physician Payment Schedule proposed rule, CMS said that consistent with the legislation that Congress passed in March, it would extend the coverage for those codes that were supposed to only be on the list until the end of the public health emergency for an additional 151 days after the public health emergency ends. Now, 152 days after the PHE ends, Medicare no longer plans to pay for the 3 CPT codes for telephone visits, or audio-only visits, as we sometimes call them. And all telehealth services would be paid at the facility instead of the non-facility rate. Physician offices, for example, are considered non-facilities by Medicare. A hospital would be considered a facility. The facility rates are usually lower, so that could be an issue. The AMA has formed a joint CPT and RVS update committee telemedicine office visits work group that's assessing the available data to determine next steps on accurate coding and valuation for office visits performed via both audio-visual and audio-only modalities. And in our comments, we urge CMS to keep its current payment policies in place, at least until this work group has an opportunity to ensure appropriate coding and valuation of telehealth and audio-only visits. The AMA also urged in its comments that CMS remove the frequency limit on nursing facility telehealth visits, which is set to flip back to once per every 14 days once the public health emergency ends. That's it. Thank you.
Thanks so much, Sandy. All right. Our next speaker is Dr. Vimal Mishra. Dr. Mishra is a nationally recognized leader in digital medicine, award-winning practicing physician, clinical leader, educator, researcher, and digital health innovator. He leads digital transformation at the Operational Center at UC Davis Health, where he drives efforts to plan, execute, and evaluate large-scale enterprise-wide digital transformation, and also serves as the Director of Digital Health at the American Medical Association. In addition to these roles, he serves on several national committees, advocacy groups, and business entities as a digital health expert and a thought leader. He has been peer nominated every year since 2017 as a top doctor in Richmond and has been awarded for excellence in clinical leadership, administration, and research. Dr. Mishra holds invention disclosures for digital health tools. He is board certified in internal medicine and clinical informatics and is a Duke School of Business graduate. Dr. Mishra, I'll turn it over to you.
Thank you. Thank you, Bernadette. Thank you for that kind introduction. I'm so honored to be here. Can everybody hear me?
Yep, we can hear you.
All right. All right, great. Thank you. I hope you all had second cup of coffee today in the morning. This is a fantastic day. I was thinking as to how to start this conversation around return on health. And I thought maybe you'll start and kind of piggyback what Sandy just talked about, the PHE and how it has impacted patient care. And I will start with a story here. I was in an inpatient ward setting admitting a patient. This patient is a 60-year-old female who lives in a rural area in Virginia, this was her third admission in last 1 month. About a month ago, she was admitted for something called as a necrotizing fasciitis. It's in layman terms, it's called as flesh-eating disorder because of infection and bacteria. And this was her right leg, which was infected. And many times, depending on the severity of the disease, you have to give antibiotic as well as sometimes surgery. And unfortunately, she needed surgery to kind of clear up the bacteria and debridement. And she got, again, readmitted in between where she was said, hey, there's no more infection, you're fine, just do wound care. And then she gets admitted third time to me within that month. And we started investigating. We got all the consults from surgical colleagues and from infectious disease colleagues and asked, that what else is needed, and everything was fine. So we set her up with a home health company and for the wound care and sent her back home. And we had a great program, which is post-discharge virtual visit program. And we connected her within 72 hours of her discharge. As soon as she opened her camera, she started crying. She literally started crying, talking about, doctor, you never told me that I am so sick and I'm dying. I'm like, what do you mean? And this was a team-based care model. So we were, my nurse practitioner, social worker, care coordinator, all together talking about this. And I said, what happened? And she said, and I asked her if the home health company talked to her and somebody came to her home to make sure that the wounds are taken care of well. Well, the company called and it was a home hospice and home health company. And that was the anchoring for her that she is that sick and she refused to get care. And this had happened 3 times. And just a powerful message here is that there's so many different ways the virtual visit and telehealth creates value. And if this patient, we did not have this PHE, we were not able to see the patient at home, this patient would be back again in the emergency department. So with that, I want to kind of go ahead and talk about our latest research. So AMA just released its latest research on physician uses, motivators, and requirements for adopting digital health solutions and emerging technologies like AI and digital therapeutics. This study is repeated every 3 years, and this was the first time in 2016 we did this study. And it was fielded by about 1,300 sample of respondents, physicians, representative of US physician population. Research finding recognizes that adoption and interest continues to increase if key requirements are met and if the solution can help improve administrative burdens and outcomes. An increasing percentage of physicians feel there are advantages in leveraging digital health solution, which is fantastic, and the interest continues to grow and adoption continues to grow. And the percentage of physicians who feel digital health tools are an advantage for patients' care grew from 85% to astonishing 93% in 2022. That's fantastic as well. Adoption of digital tools has grown substantially, significantly among all physicians, regardless of gender, specialty, or age. And then average number of digital health tools in use by a physician grew from 2.2 to 3.8, which is almost kind of double. Improved clinical outcomes, as we just talked about, and work efficiency are the top factors influencing physician interest in digital health tools. And the ability to help reduce stress and burnout has also gained importance as a key driver for digital tool adoption. The largest growth in adoption was among digital health tools that aid in remote care, remote patient monitoring, as well as virtual visits. The percentage of physicians using televisits grew from 14% in 2016 to 80% in 2022, which is astonishing, but with the COVID, I think that was necessary. While the percentage of physicians using remote monitoring devices grew from 12% to 30% in 2022. All great news in terms of adoption, and we do this every 3 years as a benchmark. So I talked about 2016 when we started doing this benchmark research, digital health research. And during that, when we initially conducted, we asked physician community as to what are their issues, how can we help them to help adopt digital technologies? And they gave us 4 questions. They asked us, we need to know, for us to adopt technology, does the technology work? So what is the evidence behind technology working? The second is, yes, if the technology works, how will I receive appropriate payment? And will I be liable? I think all those are great questions. And then the fourth part of this is, yes, technology works in the in an experimental setting. Will that work in my practice? And this actually touches on return on health because it's so contextual. Where you're applying technology, which condition you're applying technology from, and how you're applying technology to really support the patient. The AMA conducts a variety of research efforts and produces numerous resources to ensure physicians' key requirements are met. And today, we will highlight AMA return on health research and value framework. So let's jump into return on health. So the question is why? Why did we start thinking about return on health, and what was lacking? So starting with why, we have had significant experience with EHR implementation. One of the missing component of EHR implementation was, how are you creating value to the patients, to the physicians, to the healthcare system and community while you're implementing EHR? Most of the metrics in the EHR was around, hey, did the implementation happen? Did you complete the implementation? What is the financial outcome of the implementation? Is the receivable accounts getting better? And those kind of things, which were not really focused on the real care we provide using the technology. And that was a big gap. And the second was, during the COVID period, what we found is we are moving. Before 1990s, there was only one way of delivering care. That was using brick and mortar. The patient needs to come to a clinic and we see the patient, or come to the hospital and we see the patient, and there was no other way because technology were not that advanced. In starting 2005 and onwards, what we saw was there was a parallel care going on, right? There was virtual care, which was separate and apart, and then in-person care, but there was no synchronization and integration between them. There was a lot of research which was done, and it was shown that telehealth was not inferior to in-person care. And then moving forward with the COVID, we entered in an era where it's more about how do we unpack the analog care and repack with digitally enabled care with the digital tools inserted in between, and how does that improve patient care journey, its outcome, its experience. So with that, we had more than 100 pieces of literature search. We partnered with Manat. We interviewed about 18 different institutions and 18 different subject matter experts to come up with a framework, and we tested it. And that's what you're going to hear from many of the partners who are going to be talking about as what their experience has been with testing. So in a nutshell, there are 6 value streams, which should be apparent here, which is, clinical outcomes and safety, quality, access to care. And there are so many substreams under it, but we'll not go in details there today. And then experience for the patient, experience for the clinicians, and then financial and operational outcomes. So, and with making sure that equity is front and center and a cross-cutting stream across. This is more of a balanced scorecard, because if our implementation of technology is done, we need to measure and think through all those 6 value streams to make sure that implementation is fostering growth, and people are understanding what the implementation of digital health is doing for the community, for the patients, for the physician, for the health system moving forward. Just doing one analysis will not really give you the balanced scorecard. But with this, there was a lot of environmental factors which would influence what teams, what health system, what practices will get what value. So if you start kind of putting this equation together with a type of practice which is only fee for service, you might have different value streams and weightage of the value stream as compared to value if somebody is in bundle-based payment system. Similarly, payment arrangement and type of practice at academic medical center will look different as compared to private practice is going to look different. Patient population, if the patient population is Medicaid, Medicare, and have issues with social determinant of health, the implementation of technology will look different. The outcome and the value is going to look different. Similarly, the use cases, stroke implementation, telestroke implementation will look different, and the value stream is going to will look different as compared to diabetes care. And similarly, the modality we are using, e-consult, virtual visit, asynchronous telecare, all the value stream is going to look different. So with that, we have, of course, we would encourage you to share your story and try to implement return on health framework and see how that is impacting your patient population and your practices. And we would love to hear that. And through this grassroots level, we have the 7 wonderful and esteemed speakers next to me who will talk about their experience in return on health and how it affected their practices.
Great. Laura, I'll turn it over to you to introduce our first practice.
Hi, good morning, and thank you, Bernadette. My name is Laura Fritchie. I'm a project administrator on the digital health strategy team. I'm also just wanted to give a shout out to Bernadette. This will be her last telehealth immersion program session, and she's done a wonderful job with this program over the last 1.5 years. So thank you, Bernadette, for everything. I'm excited to introduce several practices we have here today, both from the AMA Telehealth Initiative as well as the Physician Grassroots Campaign. And they'll be presenting on measuring the value of virtual care in their organizations. First, we have Dr. Michelle Zena. Dr. Zena graduated from Mercer University School of Medicine and completed residency in general pediatrics at the University of Florida at Jacksonville. In 2016, she left primary care to focus exclusively on behavioral pediatrics. To complement her multidisciplinary behavioral pediatrics practice, Dr. Zena started a nonprofit to provide needed services not covered by insurance or Medicaid. In her spare time, she works with Georgia legislature, state agencies, and other organizations to improve policies impacting the lives of children with autism. Hi, Dr. Zena, and I'll pass it to you.
Thanks. I thank you for this opportunity. I really appreciate the chance to get to share part of my story. I left primary care in 2016 to reignite my passion for medicine and focus really on my very favorite patients. And at Behavioral Pediatrics of rural Georgia, the #1 chief complaint for a new patient is evaluate for autism, and the #2 is help managing complex ADHD. In our region, there are very few providers for these types of services. And as a small business owner, I've ensured viability by meeting previously unmet needs and focusing on innovative approaches like telemedicine. Because young children act very differently at home than they do in a physician office, I had previously researched telemedicine. Prior to the pandemic, Georgia Medicaid patients had to be in a healthcare facility or in an ambulance in order to access telemedicine. When the pandemic changed regulations, I was ready to make telemedicine a reality. And within a few days, I was seeing patients by telemedicine. After a few months, we did a survey of our patients, and more than 90% were satisfied with telemedicine for all future appointments, and more than 97% were satisfied with telemedicine for future appointments if in-person was an option if they needed it. Because my patients come from all over Southeast Georgia and scattered counties across the rest of the state, and some of them live more than 200 miles from my office, we have always had some challenges on getting to the office. And the only public transportation in our area is the school bus system, and it doesn't cross county lines, so it really doesn't help us at all. Everybody drives, and if you don't drive, you have to get a ride from somebody who does drive. Poor patients often struggled to find the gas money to come, and the patients who could afford the gas money struggled to take 2 or 3 hours off work to drive to the office for an appointment. If a child was not scheduled for the very end of the day, then they missed at least half a day of school, and quite often the whole day of school just for an appointment. Telemedicine saves a lot of time. We did a calculation for October of 2020, and just for the office visits with me, it was more than 10,000 miles not driven to and from my office by my patients. When you do the math, that's more than 200 hours in the car and more than 400 gallons of gas. And telemedicine has really done a lot to help us remove barriers to care. Some of the potential challenges with access to telemedicine would be internet access and low-tech literacy. Well, how did we solve those problems? We leveraged our existing partnerships. We already collected information from the school and had relationships with lots of schools for our complex ADHD patients and some of our other patients. Schools all have Wi-Fi and they all have Chromebooks. So for families without a smartphone whose child is in school, we can do video visits in the school building, which also means that the child doesn't get checked out of class. They only miss about 20 minutes of class. And more importantly, for our ADHD visits, the teacher can join us in the visit. This also works for visits with children who are enrolled in Head Start. The parent drives to the Head Start office, and we have even used the Head Start teacher's smartphone, her personal phone, on quite a few occasions in different Head Starts. When school is not in session, we often get help from PCP offices. Typically, the patients they refer to us are pretty challenging, and they take a lot of staff and physician time. So staff are very quick to assist us in getting these patients the care that they need in ways that are time-saving for them. Several organizations have inquired about using libraries, and we found that to be a very poor option. Many of our children are viewed as not knowing how to behave in the library, and the library affords no privacy. For patients who just need Wi-Fi, McDonald's has free Wi-Fi, and so does Sonic Drive-Thru. And in rural Georgia, both of those restaurants are pretty popular. Patients also sometimes use Wi-Fi from friends and relatives. So we have allowed, telemedicine has allowed us to implement a formal parent training program on behavioral interventions. As you can see, before telemedicine, half of our visits were about medication management, and a third of our visits were diagnosis and treatment plan. Only 8% were advice on, which includes teaching parents behavioral interventions. When we implemented telemedicine, we were able to dramatically increase the number of visits, and almost all of those visits were proportionately parent training on behavioral interventions. Before telemedicine, very few parents could afford the gas and the time to get a 15 or 20-minute lesson on how to get their autistic child to accept being told without pitching a fit. And now that's a service that's widely available to parents because other resources are in short supply in rural Georgia. Many of our parents are the first line for implementing behavioral interventions before their child has access to ABA therapy and other services. And without telemedicine, that would never have been possible. So I hope my story highlights some of the value of telehealth for special populations in rural areas.
Dr. Zena. Our next presenter is Michael Hoffman. He joined the Cleveland Clinic 21 years ago. He has worked for the Cleveland Clinic Respiratory Institute as an inpatient respiratory therapist in the ICU, ED, and pediatrics, as well as the ambulatory section of pulmonary function as a systems analyst. Currently, he works in IT clinical integrations as a system analyst. Michael, if you want to hop on, I can pass it to you.
Good morning. Can you hear me okay?
Yep.
Okay, great. So wanted to discuss the lung transplant program at the Cleveland Clinic. We focused on remote monitoring in this program here. It's lung transplant pre and post, specifically remote monitoring with home spirometry. The lung transplant program utilizes remote monitoring to improve the clinical outcomes of their patients. The home spirometry measurements provide data which maintain continuity of care, and also the clinic partnered with the company Monitored Therapeutics. The device you see here, there's home spirometer, which Bluetooth to any patient's smart device, and the patient can see their measurement while they're performing the test, and also the data after they do their measurement. And this data is also able to be seen within the electronic medical record by the transplant team as well. Going over the virtual care value stream here, some key points for the lung transplant program. Clinical outcomes are improved in this patient population by implementing custom alarms through the application. The alerts are triggered if the patient doesn't perform a measurement in 7 days. Also, if the patient's forced expiratory volume in the first second drops 10% 3 consecutive days, the team will be alerted as well. And those things help the providers evaluate how the patient is doing, their progress and compliance. Regarding access, being able to have these patients perform this measurement remotely provides that continuity of care and also monitoring the patient's progress and health. That improves patient access by triaging these patients, which may need to come back to the clinic sooner and get further evaluation. Engagement was also improved by the patients being able to see the data that the team is seeing. Patients and family members are always wanting to know how they're doing, where they're going with their health, and this application and remote monitoring helped be able to do that. This also helped the patient's ability to take ownership of their health, integrating them more into their team, knowing what their numbers are, seeing where they're going. Clinicians appreciated the ability to get the alarm notifications, being able to monitor the remote data and take action sooner, avoiding delays in the patient's care. Effectively monitoring these changes in condition is important for the lung transplant patient's long-term survival. Regarding financial and operational impact, monitoring the data remotely confirms and prevents the need for additional procedures in this patient population, emergency department visits, and hospital admissions. This ability to rule out unneeded procedures and hospital admissions creates the final financial benefit to the patient as well as the institution. Some key takeaways and compliments here in summary. More efficient monitoring, the real-time data viewable in the medical record is huge for the providers and the team to be able to help the patients, and greater patient access, getting them the appointments they needed, bringing them back sooner when their symptoms deteriorated. Some of the lessons that were learned by implementing this program, patient engagement was improved. Being able to see all of their data and take ownership of their care really ingrained them in the lung transplant team and their overall health. Another lesson learned was a patient support model. Important to have a dedicated, considerate patient support team. If the support team was lacking or not as effective as needed, the patient engagement would then tend to suffer, and then we wouldn't be able to monitor that health as well. Some future priorities is collaborating with other transplant centers, looking at policies, making sure they align with the needs of the transplant team as well as the patients. If reimbursement is not considered, it can adversely affect the patient, and then that also can hinder patient engagement. And the other point, lastly, to touch on is being able to expand the service to other subspecialties within the Institute, as well as being able to research the data. Collecting the data remotely is providing another avenue to continually evaluate this expanding data source. And that's all I had. Thank you.
Thank you, Michael. Next, we have Dr. William Thorneloe. Dr. Thorneloe is a lifelong member of the AMA and APA and a distinguished fellow of the APA. He has worked in downtown Atlanta in consultation liaison psychiatry for the past 25 years as a solo practitioner in suburban Smyrna. He sees a broad range of patients in both ages and diagnoses. He stopped doing inpatient work in 2003 and now focuses on outpatients. Dr. Thorneloe, I'll pass it to you.
Thank you very much. I hope everybody can hear me. If you can see me, I'm in my screen porch. I've had a bit of spinal fusion surgery the first of the month, and my wife broke her feet tripping on a pine cone, so I've been doing a lot more at home. I have previously done seen my patients from my office, which provided more privacy, less noise from my dogs and that sort of thing, but this has been a good challenge. I'm a dinosaur. I'm the single psychiatrist with a part-time receptionist. I still accept many of the insurances, and those I don't, I typically do provide a cash discount. I'm seeing teenagers to elderly, very elderly people. I'm primarily in this pandemic have been seeing a lot of mood, a lot of anxiety disorders, some serious mental illness, chronic illnesses such as schizophrenia and bipolar disorder. I'm not seeing probably as much substance abuse most, although about 10% of my patients have a history of substance use disorders. During this time, I've actually increased the number of patients, schizophrenic patients who are on clozapine, which, if folks are familiar, this is a excellent drug for schizophrenia, but it requires, when you started, weekly CBCs and DIF, and eventually can go to monthly CBCs and DIF. I think helps to provide more consistency and compliance for this patient population. Currently, I have 6 patients, which I understand is a fairly large amount. I have been using primarily FaceTime. I've been amazed how many people have an iPhone. Google Duo for the folks who have Android phones, and Meet is what it's changed into. I occasionally use Zoom, occasionally have used Doximity, which many of you will be familiar with. I've got a couple of patients who insist on Skype, and I at least know how to get to them. A lot of my geriatric patients, older patients, do not have smartphones, don't have even a Chromebook or something of that nature, and the only way to visit with them is by telephone. In at least one case, I have a patient who is blind, and meeting with her by telephone is about as good as it will get, and has been rewarding for her, and I have not been terribly frustrated with it. But the technology deficits for the elderly seems to be a significant issue. I typically see patients I know about 30 minutes, and I do a 90-minute initial exam. I use the electronic medical record practice fusion because I'm cheap, and because it lets me essentially write in a prose form, as I've been used to most of my life. I work usually from my office where it's quieter, and currently home where I've been doing a bit of caretaking. The virtual value stream, the type of practice I have is a solo practitioner. I am amazed with how many people are wanting appointments with me, and currently have not been able to take new patients because I'm fairly slammed with the current ones. I take some insurances and do a cash discount. The virtual care has been very interesting. I do see a few Medicaid patients, but typically referred by somebody who I owe a favor to. It's in psychiatry, it's particularly not worth billing Medicaid for my services, as they provide very minimal benefits here in Georgia. I would love to hear from the first presenter, as it sounds like she has a better and more satisfactory outcome there. Frequently, I will have family members in with the patient. This helps with making sure that everybody knows what recommendations are, and helps to make sure that I'm getting the history and current situation better. I've enjoyed the virtual telepsychiatry, in that it's allowed me to do a lot of things better, more efficiently, very few missed appointments, and doing this totally virtually has provided some safety for myself and my part-time secretary, who has an immune disorder, and I have had myself. The key telehealth accomplishments. I think it is much more efficient, fewer missed appointments, patients not being upset that they're waiting because somebody else was late. I have not found burnout through this to be a particular problem for me. This is as opposed to some of my colleagues I've talked with. One of the lessons I've learned is how to do psychiatry virtually. And one of the things I heard early in this is do what you do, just a bit more of it. So more hand talking, making sure that I can be heard, but speaking a bit louder, and making rapport easier through this sort of thing to try to make sure that this is a communication with a patient and not just with the green dot on my MacBook. This is not just simply a talking at a camera. One thing I wish I had was better vital signs access. About the only thing I can get is weight, and that's from my patients. You all know sometimes I have found that my patient populations, knowing what blood pressures are, knowing what how pulses are, being able to see them in person is valuable, and that is something I miss. I like when I took vital signs to be able to look for scars, tattoos. I think everybody knows that tattoos are the bumper sticker of the soul, and that sort of thing. I anticipate being 71 that at some point, hopefully in the fairly near future, the 2 or 3 years, that I'll be able to place my patients with another practitioner, especially my patients who are on clozapine. Thank you very much, and let me know if you have questions.
Thank you so much. Next, we have Dr. Barbara Rhodes. Dr. Rhodes is a board-certified OBGYN generalist at Metro Health Medical Center in Cleveland, Ohio, where she serves as an associate director of medical informatics for OBGYN. Dr. Rhodes graduated from Northeast Ohio Medical University in Rootstown, Ohio. She did her obstetrics and gynecology residency training at the Cleveland Clinic and Metro Health Medical Centers in Cleveland, Ohio. She is currently an assistant professor of reproductive biology at Case Western Reserve School of Medicine, where she serves as the third-year clinical clerkship director for OBGYN. She is passionate about teaching and mentoring residents and medical students. Her research interests include the use of the EMR to facilitate evidence-based practices to improve patient outcomes. Dr. Rhodes, you can go ahead whenever.
Good morning, everyone. My project that we were looking at was launching a Bluetooth-enabled blood pressure remote patient monitoring program with clinically relevant patient outcomes. I am talking to you from Metro Health Medical Center in Cleveland, Ohio. We are an urban safety net hospital. Our payment is 2/3 Medicare and Medicaid. We offer lots of virtual modalities, video visits, phone, texting, remote patient monitoring, patient care apps, and since the pandemic, hospital in the home. We provide care through 4 hospitals, 4 emergency departments, and more than 20 healthcare centers and 40 additional sites. We focus on providing our community with equitable healthcare. As one of America's 14 research centers for high-risk pregnancy, Metro Health has pioneered several treatments in terms of high-risk obstetrics, including using antibiotics to prevent preterm delivery, for example. We also operate one of the largest maternal fetal medicine fellowships in Northern Ohio. So for our case study, our background, we were looking at some recommendations from ACOG. They recommend monitoring all patients after delivery with blood pressure to prevent maternal morbidity and mortality, and to combat the maternal mortality crisis that's occurring in our country right now. Prior studies found that remote patient monitoring tools for blood pressure were not only effective, but the text-based monitoring was more effective in obtaining blood pressures and meeting current clinical guidelines in the immediate post-discharge period in women with pregnancy-related hypertension compared to traditional office-based follow-up. Finally, in 2022, the CHAPS trial found that antihypertensive medications with a goal of a blood pressure less than 140/90 significantly decreased rates of preeclampsia with severe features, and preterm birth without increasing the risk of low birth weight infants, making the availability to monitor blood pressures to achieve this goal a critical component of prenatal care. So in order to implement this at our hospital system, we partnered with a company that uses Bluetooth-enabled blood pressure cuffs and provided these to our high-risk obstetric patients. Our goals were to improve clinical and quality outcomes among obstetric patients, to improve the timeliness of treatment for both mild and severe hypertensive disease in pregnancy, to improve patient satisfaction with their healthcare, and to reduce no-show rates while increasing the number of touch points that we have with our obstetric patients. Little copies here. We did our value stream a little bit differently than Dr. Mishra had done in his initial slide, but it's essentially giving you the same information. For our clinical quality and safety outcomes, we were looking primarily at the rate of preeclampsia, and our goal was to decrease this by 10%, which was in alignment with the CHAPS study, which I had referenced earlier. Also, our relevant measure was to look at readmission rates for severe hypertension. This may not seem intuitive, but we actually anticipated rates to increase by 50% due to increased awareness of hypertension. Obstetric patients with severe hypertension are currently monitored in the hospital and either recommended delivery or are monitored in the hospital until they get appropriate antihypertensive treatment or until they deliver, until we decide that it's time for delivery. So we did anticipate increasing admission rates with this process. Also looking at program compliance, we wanted to improve compliance with blood pressure monitoring during pregnancy, and we improved adherence to weekly home blood pressure checks by at least 67%. If you can understand, pregnant women traditionally have to record their own blood pressures, take their own blood pressures, write them down somewhere, either put them into the electronic medical record themselves or bring a sheet to their office so that we could put them in the electronic medical record system ourselves. With the remote blood pressure monitoring with Bluetooth-enabled blood pressure cuffs, we were able to provide that data real time, immediately, and it went directly into our EMR. So this was a huge benefit. Another big goal of our clinical process was, once we get these data, how are we going to act on them? So we really wanted to answer any critical triggers within 15 minutes. So we developed a workflow of call centers, nurses, residents, and providers to ensure that if a critical blood pressure trigger was reached, that it was addressed with the patient within 15 minutes. And we were able to comply with this throughout our process. In terms of availability of care, We were looking at compliance with the program, but also looking at compliance with postpartum visits. We were able to maintain a postpartum rate of at least 60%, which is adhering with ACOG's current standard and which is adhering with the current average rate of postpartum return throughout the entire country. I will let you know in our patient population, our postpartum return for postpartum visits was much lower than that prior to implementing this app and the remote blood pressure monitoring. In terms of the patient and family caregiver experience, with the app enrollment itself, 61% of patients have enrolled in the Baby Scraps program app. And in terms of the content, on average, each user viewed 5.2 app-related educational sessions. In terms of satisfaction, 87.5% of patients indicated that being able to check their blood pressure at home provided some peace of mind. And 63% of patients felt that the experience connected them more to their clinical provider. For equity in clinical outcomes and quality and safety, our goal or relevant measure was to provide reduction in preterm births in patients enrolled in home blood pressure monitoring program to the patients in our study population. So the outcome or impact goals was reduce the percentage of iatrogenic preterm births from hypertensive disorders of pregnancy by at least 20%. So in summary, our goal to better engage and educate our patient and postpartum patients and to monitor and triage those at high risk during and after their pregnancy was a great success. Our hypertension program using a Bluetooth-enabled blood pressure cuff has enabled several things. To identify what is clinically relevant for elevated and critical alerts for obstetric patients, provide actionable data that is transmitted directly to our EMR, eliminate the need for patients to manually enter their blood pressure readings, extensive patient engagement data with 2 sources of patient education. We utilize Baby Scripts and Emmy for education and through apps, And it already, in our short process, we're under a year of doing this process, demonstrates improved blood pressure control, use of antihypertensive medications, adherence to the postpartum flow, and a trend toward reduced preterm deliveries. Our remote patient monitoring has brought to light several issues with Bluetooth connectivity at home and our area's lack of urban internet access. The city of Cleveland, Ohio was rated in 2021 as one of the least connected cities in terms of internet capabilities. Through our Institute of Hope, we have been able to partner with companies in the area to help improve our connectivity in certain parts of our city. And we hope that that will improve the number of patients that we are able to enroll in programs like this. So future priorities are again to expand our Bluetooth and EMR integrated technologies to demonstrate significantly improved patient outcomes, patient compliance, and overall patient care. Thank you so much for your attention.
Next, we have Dr. Anuruddha Das. Dr. Das is a neonatologist and assistant professor of pediatrics at Cleveland Clinic Children's Hospital and Cleveland Clinic Lerner College of Medicine. He leads the neonatology team and is department and clinical researcher. He also has a master's in public health and is passionate about reducing disparities using technology. Dr. Das.
Hi, hello everyone, and thanks for inviting me. I am going to talk about our teleneonatology program. Am I visible because I can't see? Okay. So,
we can see you.
We can see you.
Okay, great. Thank you. So we'll start off with a little bit of background. So we have 3 NICUs at the Cleveland Clinic, the NICU main campus and 2 referral units, which are in other parts of the city. And a substantial number of our infants actually go home who are very complex and who had a complex medical course in the NICU. So we actually figured a gap there, wherein babies going home were not seen by our NICU providers for a month. So the pediatricians took care of those babies, the complex fragile babies, and we thought that we will come up with a way to bridge this. Since this is a great use case for telehealth, because the babies have just been examined and are being examined on a regular basis by pediatrician. We are just kind of supplementing the work of the pediatrician over there. We thought that would be a great way to help the parents. So the objective was to bridge this gap, and we started doing that in 2018. So these were the 2 main ways we evaluated our program. So we continued to do some study on comparing the parents who utilized the post-discharge visits and who did not. And we also surveyed the parents to look if there was any value added on their side from this program. So we started this program in 2018 because we already knew that the pandemic is coming. Just kidding. But we now have almost 826 visits in 2021, and it's expanding every day. So it has exponentially grown, basically. So this report is based on about 1,000 mother-infant diets over this period of time, actually mostly from last year. And our show-up rate hasn't been great, but there are very interesting things that we found about this show-up rate. And these are mostly moms who have complex babies, and I'll come to that. So out of the 31% that did not show up, so 68% showed and 31% almost did not show up, the majority had a government insurance. And there comes the disparities, as you would recognize. So when we looked at the data for about a year, we found that the parents that showed up, or the moms that showed up, had their babies spend more time in the NICU, means they might have had a more complex course in the NICU. And they lived at a greater distance from the hospital. And the babies or the parents who did not show had a higher rate of depression, anxiety, and stress scores, which we regularly or routinely monitor in the NICU. They were also higher gestational age, the babies, and higher birth weight, meaning that they were less complex. So, it was more favorable to parents with complex babies and who stayed further away from the NICU. The survey actually showed that, and there were about 85 respondents who basically said that the virtual telemedicine Zoom visit was very helpful to them. And they actually, it did actually meet their needs, so 4.6 out of 5. And how strongly would you recommend the type of visit was 4.4 out of 5. And does this visit add any new information to the pediatrician visit? So we did this visit after the pediatrician visit so that, the babies who are going outside our system, they could bring questions to us back when they visited the pediatrician and showed up at our visit. This was also important because we were the only connection between our institute and the parents that were going outside the system to see the pediatricians. So some of these complex babies had a significant number of issues going on, and they would bring back some questions from their pediatrician. And we could connect with the pediatrician and try to resolve those issues. So in conclusion, there is a disparity that we found. It was very interesting that parents who visited more during the NICU stay also, were showing up at the post-discharge visits, meaning that the gap, the insurance gap between the government and the private insurance persisted even after the discharge. So it keeps going, actually. And we hypothesized initially that the telehealth will be able to bridge that gap, but that wasn't the case. Parents who had issues accessing the NICU during the stay of their infants actually had issues accessing the post-discharge visits too. The interesting things that we also found was that the parents who stayed far away, it was more useful to them, and infants who had complex needs. And the survey suggested that we added some value for the parents, even though they had just visited the pediatrician. So moving forward, we are encouraged by the program. And we started, this year, we started 2 new programs of virtual prenatal consultation, meaning we are actually providing appointments to parents who have a lot of questions because their babies are at a higher risk for being admitted to the NICU. This is separate from the fetal care center. So this is a separate service that we started. And we also were able to start the telelactation program for breastfeeding mothers who are leaving the NICU this year. Future directions. So our research actually showed that parents leaving the newborn nursery, and we have a huge system with almost 14,000 deliveries in the Cleveland Clinic system. So these parents who are leaving the NICU, leaving the newborn nursery, also had lots of questions, which we were not able to answer as well. We are doing a great job with the NICU parents, but not the newborns who are leaving the newborn nursery. And it seemed that there was a lot of questions that remained unanswered because even after the pediatrician visit, they still continue to have them because of the limited time the pediatrician can offer for them. That is one thing. The other is, if you imagine bringing 1 or 2 or 3 children with you on a car at in Cleveland in the cold weather, and parking and going to your pediatrician, bringing them back, it caused a lot of anxiety for the parents. This is all anecdotal, but it is true. And sitting in your home and just talking and having a quick chat with a neonatologist or a pediatrician is always preferred. That's what we found. So telemedicine actually has a specific role to play in that kind of situation. We also thought that telemedicine on demand can be useful for parents who have questions, who go home and can't find the appropriate time for a visit with the pediatrician. And we think that utilization of telehealth could reduce medical costs and morbidity and mortality in our population, at least in the NICU population. All right, that's it. Thank you very much.
Thank you. Next, we have Nikita Dediya. Dr. Dediya practices vascular neurology at Riverside Methodist Hospital. She completed her neurology residency from Case Western Reserve University and completed her vascular neurology fellowship from Ohio State University. She is currently staff neurologist at Ohio Health.
Thank you. Thank you for providing me this opportunity to present our work on this AMA Virtual Care Tele initiative. I'm a stroke neurologist, and we had developed this interest in technology even way beyond pandemic to deliver stroke care in remote areas due to its time-sensitive process. Initially, when the stroke care and acute stroke care for thrombolysis started, we used to do it on phone, The symptoms weren't clear, and then at that point, we started using videos. We used to do it on Skype, FaceTime, and then we developed this telerobots where we could actually assess the patient while administering acute stroke care, transferring them. And so this has been well established for many years. And so when the pandemic hit and we wanted to expand this care further, away from the emergency rooms, we wanted to expand this care. We went ahead and wanted to see how we could provide more care, because of the burden of stroke, as you can see, is pretty high, and with pandemic it even went higher. Almost 1 in 6 deaths were from stroke in 2020. The rest of the statistics also is very concerning, with the amount of cost, and it's being the largest cause for long-term disability, loss of jobs, long-term cares, and things like that. Out of all the strokes, ischemic strokes were known to be the longest and responsible for serious long-term disabilities. So we focused on ischemic strokes because that was the population we were getting more, and we wanted to establish a pilot project with ischemic stroke patients. So just to give you a little bit of overview of stroke care, once you have a stroke symptom, you have an acute care in the hospital, then you are discharged. After you survive the acute care, you get discharged to rehab or home, and then you have your outpatient care, and then after the outpatient care, your follow-ups to prevent further cardiovascular or cerebrovascular events. And that's the established flow from diagnosis to recovery, with the goal to get you back to your baseline before you had the stroke symptoms. And there are many models where this has been going forward, how we establish that. And the most popular model is of the spoke hospitals and the satellite hospitals and the spoke and the wheel model. And so our Ohio Health Stroke Hospital has a widespread model where we have one comprehensive stroke center in Columbus, Ohio, which is surrounded by the 4 primary stroke centers around the Ohio. And then we have all the satellite hospitals in the rural central Ohio. And so that made us possible to apply this technology, especially in the inpatient stroke care, where we had to keep the patient there and not have them transferred to comprehensive stroke center just to get stroke care. And we were trying to figure out how we could provide utmost stroke care in the community where they don't have to transfer if there is no acute intervention needed or acute neuro ICU monitoring needed. So we partnered with 4 of our satellite hospitals. 2 of them were primary stroke center, of course, and then 2 of them were non-primary stroke centers. Out of the 2 primary, we set a protocol where we see the patients who come in with stroke symptoms. We provide appropriate stroke care acutely, what they need, if they need thrombolysis, if they need interventions, if they need surgery, if they need ICU monitoring. All of that was done by the acute telestroke model in the ER when the patient is first brought up there. And then we basically determine whether this patient was okay to be admitted to one of our community satellite hospitals, and whether we could manage the stroke and the stroke symptoms there. And what our protocol was, we included only stroke, which were ischemic strokes or TIAs, transient ischemic attacks. We did not include any hemorrhages. We did not include any larger strokes. The centers that we wanted to admit the patients were equipped with all the diagnostic facilities that were needed, like CT, MRI, echoes, cardiologists. We also trained our nurses and ancillary staff in the stroke units where the stroke patients were admitted. And then we made sure that rehabilitative services were present and there was a proper discharge planning noted. And we started implementing our pilot project almost at the start of the pandemic, the start of 2020. And over the period of 2 years, we saw over 66 patients who were admitted with acute neurological or stroke-like symptoms. And interestingly, more than half of them were diagnosed with having an acute stroke, either radiologically or clinically, and were admitted for further workup for the same. And that's the typical protocol that any hospital goes through when you have a stroke patient. You need to admit them to make sure that there are no post-stroke complications, to see where the stroke is coming from, and see what the plans are going forward so that we could help the patient get back to their baseline before the stroke. The goal to implement this was to minimize the transfer from the satellite hospital or the spoke hospital to the main hospital, or the comprehensive stroke centers where stroke subspecialists were available. We wanted to provide utmost care. We didn't want to take away the quality of the stroke care that we would provide. We wanted to decrease any stroke post-stroke complications that would develop, infection, DVTs. Wanted to make sure that is all. We wanted to get all the guidelines that are recommended by AHA being applied to these patients. We wanted to have them get their rehabilitation, discharge them as soon as possible, because we didn't want to keep them if they didn't want to be, if they didn't require to be in the hospital setting, especially during COVID. And then we wanted to make sure that they get full follow-up, a proper follow-up, according to the AHA guidelines. And so that's how the protocol was set up. And initially, we made sure that these hospitals had our stroke robot there. The nurses were, and the other staff, for example, speech therapists, physical therapists, the hospitalist model that admitted the patients, were all in agreement with us telerounding. So we were basically providing inpatient stroke care for admitted patients, along with our team, multidisciplinary team support. So in terms of the results, as I said, we had 44 patients who were admitted with stroke, out of which 1 required transfer due to complexity of the case, and the other one that was transferred was non-stroke related, needed cardiovascular intervention. The median length of stay, which was our goal to keep as minimum as possible, was 2 days. Out of all the patients who were admitted, 4% of them were COVID positive. So we wanted to keep them and try not to transfer them back and forth with COVID positivity, the transfer issues with COVID positivity and things like that. So the goal was to keep them, if it was okay and the bed availability was there, to keep them in the community hospital. And our outcomes were we mainly focused on discharge destinations and clinical outcomes in terms of stroke scale severity and post-stroke complications. In terms of discharge destination, majority of them went home, either home alone without any home health care, if they were ambulatory with no risk of falls, with outpatient rehabilitation, or with home health care. Getting home health care was also very difficult during COVID surge because of the unavailability of the staff to go due to COVID positivity of the patients. So we tried to have them establish care at home with all the services that they required. 24% of them went to the rehab facility, and they were mostly because of the comorbidities that they required, not alone secondary to the stroke. 5% of them went hospice or had died because of the COVID complications or old age or other complications from associated comorbidities. The main protocol that we had in our stroke patients was to make sure that they did not have any major vessel abnormality in their brains or in their neck, extracranially or intracranially, because that we have known has increased rates of complications, requires transfers and things like that. So we kept those patients that had very minimal vascular problems. And so looking at our etiology, we gathered that this would be mostly cardiac etiology that would possibly these patients have. But to our surprise, a lot of them were just unknown etiology. ESUS is embolic source of unknown etiology. And so those patients, 30% of them were our targets to make sure that we have good follow-ups. We continue to keep them in the loop to prevent secondary stroke events. 21% were cryptogenic. Again, we didn't know the cause, so we kept them in the loop. And 7%, as I said, were just large vessel disease, which we were minimum and we controlled. The other parameters that we actually came across was the stroke scale severity. The symptoms that they came up with at the 30-day follow-up was 0. So they all recovered pretty much from their disability, although given that the patients that we admitted were minor symptoms, so you would expect them to recover, but we kind of established that. And the most interesting fact that we realized after they had seen a subspecialist giving them stroke education, showing them their scans on the tele monitor, telling them what stroke is, educating them, spending time with them on the tele monitor, where other doctors who had to go in and out because of the COVID couldn't spend time with them, sort of established this good patient doctor relationship that they actually followed up almost more than 50% of the time. And it was even interesting from the data that we collected in our comprehensive stroke center, where we had seen the patient in person, their follow-up was almost 40%. So this was within 90 days, we had a good follow-up from the community to come all the way to Columbus, drive all the way to Columbus to make sure, to see the stroke doctors to make sure that they don't have any other stroke etiology left unworked. And then they never, none of them, 0 patients had, those who were discharged either home or in the rehab facility, had any post-stroke complication, any cardiovascular event 30 days from the discharge, which is another clinical outcome that we were looking for. So all in all, you know, we kind of established inpatient tele-rounding in assistance with the tele-robot and assessing patients, stroke patients with a stroke subspecialist is a very effective tool, especially in patients who have minor stroke symptoms or TIAs that do not require acute intervention, does not need transfer from a community-based hospital, which does not have a stroke physician, to a comprehensive stroke center. This would actually improve, tele-rounding improves post-stroke compliance and follow-up and builds a community trust within the doctors and the patient. And especially during COVID, it helped appropriate triage, resource management, and did not hamper patient care. That was our main goal. So there are various ways to apply the tele-stroke model, just not in the ERs, but also we are expanding it to apply in the outpatient setting, in the rehab places, especially with our colleagues like speech therapists, physical therapists, occupational therapists going forward. Thank you.
Thank you. Last and certainly not least, we have Dr. Donna Seminara. Dr. Seminara is the medical director at Eager Healthcare and Rehabilitation Center, as well as director for the Division of Geriatrics at Staten Island University Hospital of Northwell Health. She is a master of the American College of Physicians and past president of NYS chapter of ACP and Richmond County Medical Society. She is also aging chair of NYC Community Board 2.
Hello, good afternoon. I'd like to take the opportunity to thank the American Telemedicine Association and the American Medical Association for the opportunity to share information about the telehealth journey at our skilled nursing facility. Eager is a 378-bed skilled nursing facility with primary care services that include both short-term restorative rehabilitation, and long-term care. Our payments are primarily from Medicaid, Medicare, and also other third-party insurers. We did pursue also some private telehealth grant funding to get us off the ground with our telehealth experience. Our patient population is primarily very elderly persons with multiple comorbidities. Those on short-term restorative rehab are transferred from acute care institutions, and they are increasingly in unstable conditions. They also often need subspecialty input to follow up their care, and this is where we really established that we had a significant challenge. Especially this was true post-COVID. Before COVID, we had fewer and fewer subspecialists coming to our facility, but during COVID, that completely dried up, and subsequently, we have had the return of very few subspecialists. Particularly, we've had no cardiologists, pulmonologists, GI interventionalists coming to the facility. Our virtual care modalities that we are offering are both video and video telehealth, as well as phone telehealth platforms. The virtual care services that we offer are consultative services with specialists, geriatric care collaborative evaluations between the hospital and the nursing home, and also utilization for on-call coverage. Our workflow design is really surrounding the patient. Our challenge was that patients would be discharged from the hospital for short-term restorative rehabilitation and have a laundry list of physicians with whom they were expected to follow up. These are highly debilitated patients who frequently were not physically capable of a lot of mobility and traveling back to subspecialty offices. There were also financial challenges with doing so. For instance, Medicaid will not pay for transportation services for someone who is in restorative rehabilitation if they're going to go to an office. So that put financial burdens on the family and was often a significant barrier to achieving that subspecialty care. So I'd like to point out that when we talk about disparities in care, you can have a nursing home that is literally within a mile of a hospital with many subspecialists in the immediate vicinity. However, access to those doctors can be as far, it would be as if the patient were 200 miles away. They just can't get to their offices. So we needed to coordinate a process where we were operationalizing getting these visits done. We had a single point nursing home referral process for telehealth established here at Edgar. And because of my links with the geriatric department at my local hospital, I was able to get a single access point there as well, so that there would be one person responsible at the nursing home, one person responsible at the hospital, coordinating these visits across multiple different subspecialty units. And the virtual visits could then be easily scheduled. Operationally, this took quite a bit of time. I'm going to just describe for you a little bit of how this workflow worked for collaborative consultations for geriatric patients with advanced comorbidities. And that's where Edgar linked specifically with Staten Island University Hospital, where I, as the medical director, worked closely with Anita Serzin, who was championing telehealth at our Division of Geriatrics at Staten Island Hospital. And the goal was really to optimize shared information and to streamline treatment plans to specifically avoid the potential for early readmissions back to acute care from the nursing home. The practical tasks that had to be addressed were getting grant funding for hardware, software, and for personnel. We had to operationalize the workflows, as I had described earlier, in scheduling such appointments. And then we had to directly supervise training those who would participate in these calls and launching the program itself. The clinical outcomes and quality and safety issues were really to focus again on the avoidance of unnecessary emergency department visits and to get early adoption of programs to enhance care when the physician is not in the facility. So for instance, when doctors were not here and they only come in and round and then leave, they are not staff doctors who are here all day, by allowing nurses to utilize telehealth protocols, we were able to initiate sepsis protocol initiations very quickly by having a quick visit with the primary care provider and the staff nurse along with the patient. The physician, who would know the patient well, would be able to evaluate the patient's symptoms, their change in status, collect data very quickly, and initiate intravenous fluids, intravenous antibiotics with vancomycin and meropenem, start sepsis data collection with labs, blood cultures, x-rays, etc., and hopefully try to capture patients who are on the brink of sepsis with altering vital signs, tachycardia, hypotension, etc., and turn their course around with a very quick initiation of treatment. Access to care, again, was overcoming barriers, the financial ones, the cost of ambulance transport services, as I had mentioned earlier, operational problems where subspecialty offices would be overwhelmed by our patients who would be transported in stretchers and wheelchairs, addressing the issue of patient fatigue, where patients having just left the hospital would often put up resistance to being immediately transferred to subspecialty visits because of fatigue with the healthcare system, feeling that they needed more, sometimes emotional rest and not just physiologic rest as well. Also, access to subspecialists significantly needed to be improved, especially as after COVID, subspecialists were not coming to the nursing home. We also were working on the experience of the patients, families, and caregivers. It was physically easier for debilitated patients to see subspecialists. The families and caregivers overall really liked the ability to be able to remotely participate, even if they weren't at the nursing home and they were at work. They would be able to participate in a three-way dialogue with the patient and with the subspecialist. The clinical experience really improved our ability to have meaningful treatment plans. Vague recommendations that previously had come on scribbles of paper sometimes were able to be clarified on the spot. And things that would not be manageable in the nursing home were able to be immediately redirected back to the subspecialists, so that we could have clear, practical paradigms for evaluating patient status and doing things that were doable on the part of the nursing home. Excuse me. From the perspective of busy specialists, the financial and operational impact was very significant. They can be reimbursed for the visit. They don't waste travel time. And at the same time, the nursing homes really needed their input to manage very brittle cases. And in this way, the financial impact was really cross-directional and aligned. Both the hospital and the nursing homes would be able to avoid emergency room readmissions within 30 days of acute care discharge. In situations where there are specific diagnoses, such as congestive heart failure, COPD, and pneumonia, if there are readmissions within 30 days, CMS would do Medicare financial clawbacks for those readmitted patients. So incentives were definitely financially aligned, and this really helped to get champions on both sides of the healthcare aisle, at the nursing home and at the hospital, aligned to make this process work. Our key accomplishments were, frankly, getting started and formalizing the process. We have seen a positive impact on care, and we know that we have made life easier for patients who are very heavily burdened with a significant physical and mental illness. We know that our best transitions of care and the best adaptations of meaningful treatment plans are with subspecialists who have mid-level providers available to assist with the visit coordination. Those visits are the smoothest with video telehealth, and having that operational flow optimized with mid-level providers, setting it up for the specialist really is key. We also found that if we were able to contact the provider who cared for the patient in the hospital, that also provides the most meaningful data. Certainly with a video telehealth visit, a picture is worth 1,000 words. And some of our cardiologists and pulmonologists, when we have data that may demonstrate failing, for instance, increasing acute kidney injury in a patient being treated for congestive heart failure, the cardiologist would be able to look at the patient, auscultate with the use of peripheral equipment, and be able to tell us whether the patient was indeed actually better or worse than they were in the hospital. It's given us very meaningful, real-time direction in terms of helping to coordinate care for our patients. Our future priorities are improving the Wi-Fi capabilities here in the nursing home and for the pursuit of dedicated staff here to manage the implementation of these visits. We want to enroll more specialists in the program and train their staff in visit implementation across all of the different software packages. And we try to utilize different packages to make it easier for whichever specialist for whatever program the specialist is comfortable with. I want to thank you for your attention and would be happy to answer any questions on the use of telehealth in the skilled nursing facility environment. Thank you.
Wonderful. Thank you, Dr. Seminara. All right, we will move into the Q&A portion. I invite all speakers to turn on your webcams and invite all of the audience members to submit questions either via the chat or the Physician Innovation Network. We will be monitoring both. I've collected a few so far, so I'll kick things off, and I've grouped them together by some of the speakers. So our first question is for Dr. Barbara Rhodes. The question is from Jennifer Hone, and it is, did you measure the difference in outcomes stratified by payment type or socioeconomic status?
So we did not in our study. We do have that data. Our study was not large enough. In total, we had about 500 patients enrolled in the remote blood pressure monitoring. And when we did look at insurance type, we did not see a difference. That helps answer, but we're collecting more data, so we'll see.
Great, thank you. All right, our next question is for Dr. Das. The question is from James Peak. Were there any improvements of clinical outcomes? And then building off of that, we've got a follow-up question. What are the clinical outcomes of those with similar risks that used or didn't use the telehealth visits?
Yeah, I kind of answered that in the chat. That's a very relevant question. So the biggest confounder that we found in the dyads, the parents that showed up and did not show up, was the socioeconomic factors, the SDOH. And I think that has a very significant effect. Even in our research, when the babies were in the NICU, there was a big gap between parents who came in to the unit and who were not able to come in that often. Very interestingly, though, during COVID, what happened was there was a lot of restrictions. And this is another research that we already published, that parents from higher socioeconomic strata were also prevented from coming into the NICU. And that was because of the restrictions that the hospital put in or the state put in. And then we saw that there was no difference in between the government insurance parents coming in and the private insurance parents coming in, which was very interesting to us. But the fact is that those babies who do not show up in the follow-up visits very likely do not show up because of a strong SDOH factor, and they actually eventually don't do well. And I think it will be unfair to say that they don't do well because they didn't show up in the post-discharge visits. I think it's more to do with their socioeconomic background.
Great, thank you.
Was that the answer, or there was another part to that?
Yeah, the second part was, similar risks that used or didn't use telehealth visits. So did you notice a difference between those?
So that was kind of the answer. So if you adjust for all the confounders, the biggest one being the SDOH, and the issue is after discharge, the medical issues kind of are not that significant, but the social determinants of health kick in more. And there is a gap of about 2 years before which, the major outcome, which is the neurodevelopmental outcome of the preemies, are assessed. So this 2 years gap, this is what, our objective is to look at that. Is that 2 years, I think there's a very significant effect of the social determinants of health on these babies. And the outcomes are poor, not only because of the medical issues, but also of the background, social determinants of health background of the parents. So I think that's a big, major issue.
Great, thank you.
And Bernadette, I will just kind of chime in with what Dr. Das said. It's such an important issue of the digital divide. And I think it's really important for us to thinking about, as we're implementing digital health, we should not be leaving people behind. One of the things we have done here to make sure, not in the NICU population, certainly, but in the other population, is we do take a questionnaire to make sure that when we are discharging, we have the digital navigators and programs which would take that history to see if the patient have the appropriate digital technologies and access to digital tools when they are discharged, so that we can provide the care. If not, how do we support them during that transition period? Or do we have to create a personalized pathway for that patient as well? And that has worked, but at the same time, having that cognizant thought process of discharging patients with that understanding that there might be issues around, and really does help. In our post-discharge hospital discharge clinic, it was about 30% of the patients. And we asked if there are family members. And, I had a patient who was, 80 years old, new kidney failure, on dialysis, could not see well, could not hear well. And then when I talked to the patient's family, they were like, we would love for her to be seen after this. We will be there at the patient's bedside. And we saw the support of the patient by the family really gave us confidence. So I think there are a lot of different ways to think about it.
Thanks, Dr. Mishra. All right, our next questions are for Dr. Dediya. Question is, what cardiac parameters did you telemonitor? What devices did you use for telestroke, and how did you fund it? And then did you find a difference in clinical outcomes using telestroke technology?
Yeah, so for now, first was the cardiovascular monitor. So every stroke patient gets telemonitored. They are admitted in telemonitoring beds. So they get blood pressure, heart rhythm monitored, pulse ox monitored. Depending on the severity of stroke, it's first 24 hours to 48 hours that we monitor those. And every patient till discharge and after discharge gets cardiac monitoring to rule out atrial fibrillation. As you saw, cardioembolic stroke was the highest etiology that we could find. So they all get those whom we think we couldn't find the cause, or we thought there was AFib that was not detected during inpatient, gets post-discharge cardiac monitoring, portable Holters. There are varieties of monitors available in the market that we give according to the patient's choice and their insurance coverage. The telestroke device that we used are from the teledoc stroke robots. They're also used in the ICU, basically. These were funded, I think, by my hospital even in 2016. We basically, all the teledoc robots were installed along with the teledoc or teleprovider company when there's acute stroke treatments and telestroke benefits were established in 2010 with AHA along with American Stroke Association. So we already had the setup, and we were doing this since 2016 for acute strokes, basically. So a patient comes in the ER, we see them, we assess them, and we determine what they need. If they need TPA or thrombolysis, we give them. If they need to be transferred, flight over, or to get surgery or thrombectomies, we determine that. So we have been working with this model since 2016, and we've been improvising on that perspective. So we use the same robots in the inpatient setting, seeing the patients while they were admitted with strokes. So in terms of funding, initial robots, I think it came through the hospital itself, with the hospital equity. And then the rest of the robots for the inpatient were, if I'm not really sure about what exactly the funds were from, but mostly from the hospital equity is what it came from.
Great, thank you. This next question is for Dr. Seminara. This is from Elaine. Congratulations on your success. What sources did you use for grants obtained to implement telehealth in a skilled nursing facility?
Sure, thank you. So we did go to some private firms. For instance, the Samuels Fan Fox Foundation here in New York City was able to provide us with a $200,000 grant that really helped us kick off with software programs, training, etc. And that was a link between our local hospital, Staten Island University Hospital of Northwell, along with Egger. We also went to our local politicians and we asked for grant support to be able to enhance telehealth communications and all communications by enhancing Wi-Fi in our facility specifically. So we found them to be excellent sources of small grants, sometimes, $5,000, sometimes $10,000. There was also a project by a consortium group that was put together locally on Staten Island, where all nursing homes did receive a seed money of $15,000 each, also for the purchase of a specific telehealth program. So there was money available. It did require a lot of scratching around to find sources. And we are always, looking for more because in our nursing home environment, finances are very, very tight. There isn't extra money for some of these programs. And I also really want to emphasize that you need to find champions, people who are advocates for telehealth within the communities that you're working in when you're not associated with a large institution. Our nursing home is a freestanding, independent nursing home. We're just in the process actually of joining a network, but we initiated this when we were very much on our own and alone. But I really saw how telehealth enhanced the provision of care I was able to give in my private practice and also in a home visit program that I monitor through my local hospital. And I was very confident that we could address some of the challenges that we were seeing here in terms of accessing specialty care for our nursing home patients. So it was looking around for private sources of funding and then really tapping onto the passion of champions to get the programs off the ground.
Great, thank you. Okay, this next question is for everyone, for all the speakers. This is from Melissa Ward. What is your best advice on improving provider adoption to get programs to a level of success? And Dr. Mishra, maybe I'll pick on you to go first.
Can you repeat that?
Sure. So it's, what is your best advice on improving provider adoption to get programs to a level of success?
Yeah, I think exactly what you all have done. I really kudos to the programs you have implemented, the outcomes you have seen, and the way you have evaluated really gives me so much of excitement as to, because many times we just talk about one aspect of outcomes, that is, hey, was it financially viable or not, or maybe operationally viable or not, the workflow is working or not. But just having that value stream in front of you where you're seeing clinical outcome, which is our near and dear, and all the physicians really care about it. That's why we went to medicine. And then showing how it is also improving the operational outcomes, financial outcomes, experience, access. It just gives you so much more of confidence that the things you're doing, the programs you're implementing is working. And I think that's one of the most important things for physicians. What I have seen in my own practice as well is if you start showing the value, they will be taking it on. And that's what happened during COVID. And that's what we are doing here as well. So I think that will be my biggest nugget here.
Great, thank you. Any other speakers want to weigh in?
I can give you an example. So, 5 years back, I introduced the concept of telehealth to the fetal care center, and it was interesting that at that time the director of fetal care center said, it's fine talking to the parents, to the mom about congenital anomalies and that your baby, may not survive after birth and may have lots of issues, congenital issues with them. But I'm not comfortable talking to the parent and giving them bad news over telehealth. So, I'm not going to do it, but in some cases I will, because, this is a facility, this is a new technology that is there. And for my moms who are not having very, difficult congenital anomalies, like not significant ones, I think I can use it. So I said, okay, why don't you try it? So in the first year, I believe is 2017, they saw like 5 moms through telehealth. Believe it or not, in 2021, 80% of their visits were via telehealth, because it doesn't require any examination of the mom. So this is just a discussion that they were comfortable having over telehealth. This is a great example because they have adopted to it by using it. So introduced slowly, getting comfortable, and then they really started using it well, which is a great example that it's just about the provider comfort, about what you're willing to discuss and what not, and slowly, eventually, you adopt it.
Great. Thank you, Dr. Das. Oh, sure.
No, I just wanted to say that from the geriatrics perspective, there are tremendous benefits in telehealth also. And one group that wasn't really discussed today were those who are homebound. A homebound patient really can benefit tremendously from telehealth because it's very rare that you can get a physician into the home on an emergent or urgent basis. As the manager of a home visit program that handles over 400 patients, I can tell you that over COVID, it was invaluable to be able to have telehealth services to establish contact with patients who were frightened, who were socially isolated, and who really needed a lot of social attention. We also have found in this particular patient population that teledermatology is very helpful, as well as telehealth psychiatric services. I know we had a psychiatrist speaking earlier, and I would be interested in his feedback also on the benefits of telehealth for the geriatric populations.
All right, Dr. Thornlow, did you have a comment? I'm not sure if we can hear you. All right, in the spirit of time, I'm going to keep us going forward. I apologize. I know we could probably have a really rich discussion for hours on end on this important issue. And thankfully, too, we will continue to have our Physician Innovation Network virtual discussion platform open. All of our speakers will be on that platform as well and can answer questions offline. And then just a couple of housekeeping. We do have a few program announcements to make. Our next event for a telehealth immersion program will be held on October 16th, and we'll walk through the AMA's latest digital health research findings published earlier this month. Dr. Mishra had mentioned this earlier in his presentation. This research highlights physician usage of digital health tools, motivators, and requirements for adoption. We field this every 3 years, and this report highlights overall trend comparisons since 2016. We also, our colleagues in Health Solutions are hosting a webinar as part of the CPT webinar series focused on digital therapeutics. This will be presented by Megan Coder, founder and chief policy officer at the Digital Therapeutics Alliance, and Zachary Holschletter, director of CPT editorial and regulatory service at the AMA. And this event will cover topic areas like what makes a digital health product a digital therapeutic, what considerations are necessary for implementing digital therapeutics in clinical use, and how CPT codes can enable the integration of digital therapeutics throughout the course of care. So registration for both of these are available, and we'll include that in the post-event communications. Lastly, just to wrap up, we do have a survey that will be going out in the email. We thank you in advance for completing that. And I'd just like to thank, again, all of you for joining us. A big thank you to all of our speakers today who have volunteered to share how it's working in their organizations and really share invaluable insight to the broader community and benefit of our country. And I just wanted to also shout out a special thanks to several organizations that we have been working very closely with over the past year. This includes the Physicians Foundation, the Medical Society of the State of New York, the Academy of Medicine of Cleveland and Northern Ohio, the Montana Medical Association, the Massachusetts Medical Society, and the Iowa Medical Society, who have been instrumental in making this event today possible. All right, well, thank you so much. Have a wonderful weekend, and we hope to see you soon.